Thank you, Richard, and it gives me very great pleasure to address you this morning. I've heard of hot topics for many years, and now I can see what the fuss is about. What a wonderful meeting. Congratulations and thank you. One of the reasons I was very keen to accept this invitation was because of two of the people who are in this session and who have had such a big influence on the talk I'm about to give you. And the first is Professor Alan Jobe. I trained with Alan at UCLA in the early 1980s, and for 30 years Alan has come to my town of Perth in Western Australia each winter, your summer, to do collaborative research with us, and we've been funded by NIH for 27 of those years together. And without Alan, I don't think we would have ever been able to crank up the perinatal research that exists in Western Australia. And on behalf of all of us in Western Australia, I'd like to publicly thank you, Alan. The next thing I'd like to say is that as a young obstetrician and maternal fetal medicine specialist, I could see no greater and more noble task that I could pursue for my country, for my population, and for everyone, really, than to discover how to safely lower the rate of preterm birth. And I'd been sitting in this very unique place of Western Australia for several decades, knowing I had the ability to introduce a statewide program, but being aware of the fact that I didn't have the appropriate interventions. And it was in 2013 at SGI, our annual meeting here in the United States, that I was listening to Roberto Ramiro go through the various interventions, describing his trial with Sonia Hassan, showing that vaginal progesterone will effectively provide level 1 evidence of a reduction in preterm birth. And it was during your presentation, Roberto, that I had the strength and knew we had the evidence and the support to embark on a whole-of-population statewide study. So on behalf of all of us in Western Australia and now Australia, Roberta, I would like to thank you very much for your support and knowledge. Thank you very much. So now I'd like to tell you how the story evolved, and first of all, I have no conflicts to declare. The work that I'm about to present has been funded largely by the Australian government through the NH and MRC and various health departments and some philanthropy. And the first half of this talk is describing what happened in Western Australia, and this has been published last May in the American Journal of OBGYN as the report of major impact, showing what happened to our whole-of-population statewide preterm birth intervention package. And if you'd like to read further details, you can find it in there, as well as other references articles we've referenced on the justification for why we did what we did. What we did was we decided to go for our low-hanging fruit, and I'd like you to imagine a very different environment from that in which most of you work. Western Australia is the western one-third of Australia. The land area is one-third the size of the United States. It has a population of 2.5 million people spread out over that entire area, but relating in obstetrics and gynecology to one tertiary level centre in the capital city, which is Perth. So we have a very integrated system over a distance of more than 2,000 kilometres relating to one tertiary level centre and one academic structure. So we have a very well-resourced, very well-coordinated structure, but spread out over a very large distance. So we unashamedly chose interventions that we knew would work in our environment and for which we had evidence of effectiveness. Now, these are the 7 interventions we chose, and the package is called the Whole 9 Months, which is a trade-named name. So the 7 interventions are, first of all, no pregnancies to end before at least 38 and a half weeks. That was a negotiated compromise with our colleagues. We now say about 39 weeks is the official phrase we use in Australia. So no pregnancies to end before nearly 39 weeks without obstetric or medical justification. Next, we introduced measurement of the length of the cervix at every mid-pregnancy scan between 16 and 24 weeks across our entire state. Our whole population has scans in mid-pregnancy. It's a very well-resourced environment, very ultrasound-intense environment. We knew we could do this. We just needed to provide the education and embark upon it. Then we set up a system such that any cervix shown to be less than 25 millimetres in mid-pregnancy would receive vaginal progesterone that night. So we needed to set up a system with all our referring docs or every healthcare centre throughout our vast state, such that the progesterone was available and be prescribed that day. We then embarked upon making sure that any cervix that was shortening on treatment would be then assessed for cerclage or just continuing progesterone. We also gave progesterone for any history of prior preterm birth. We beefed up our anti-smoking campaign through our health department, and we started a dedicated new clinic in our major centre for the very high-risk cases of recurrent preterm birth. So this, for people who don't know who aren't used to looking at a cervix, this is a cervix on transvaginal scan, and on the left you will see here we are. On the left, you'll see this is a normal cervix on transvaginal scan. This is the internal os, the external os. This has a length of 34 millimetres. This is a very normal cervix. So a long cervix in mid-pregnancy predicts later birth. A shortening cervix predicts early birth. And this in the middle shows a shortening cervix. This is the one we're hunting for. This cervix is shortened. There's funneling leading down to it. Its distance is 13 millimetres. This woman needs natural vaginal progesterone tablet vaginally each evening from now on until 36 weeks. And on the right is what we want to never see. This cervix is gone, and these are membranes bulging down into the vagina. And natural vaginal progesterone, we now know, will nearly halve the risk of preterm birth in a woman with a short cervix. We don't do transvaginal scans on all. We do an abdominal scan with a full bladder. If it's 35 millimetres or more, that will suffice. If it's less than 35 millimetres, or we can't see it clearly, or she has a history of preterm birth, she gets a vaginal scan. And then we saturated this with a social media campaign called The Whole 9 Months. And it's been a print campaign through our newspaper. We put out magazines periodically through our newspaper. We produce 160,000 at a time. They go throughout all the waiting rooms in doctors' practices and hospitals throughout the state. And then the social media campaign we've put a lot of work into. So there's a hashtag, The Whole 9 Months. There's Facebook, there's Twitter, etc., and we have a person employed to make sure that just about every day we have new stories going out, very short stories and short video clips going out frequently onto The Whole 9 Months so that people can follow it on a daily basis. No video clip is allowed to be more than 7 seconds, which is the maximum duration of concentration of young people these days. Their thumb cannot dwell for more than 7 seconds. We then knew that doctors don't read anything, and if you write to them, they don't read anything, they don't do anything, they don't follow Facebook, most of them, so we knew we had to go to them. So we set up an outreach program, which I led with a junior obstetrician, a woman called Suzanne, our chief sonographer, and she won the award of Sonographer of the Year for Australia for doing this, and then one of our specialty preterm birth prevention midwives. We're building that up as a specialty. And we then travelled throughout all of Western Australia. So we did a distance of 13,000 kilometres periodically, running evening workshops in country hospitals and city hospitals to make sure that no doctor or healthcare professional was left behind, that we made sure that everybody understood the new protocol. I wrote to 2,400 doctors and healthcare centres when we launched this during 2014 to make sure that everybody knew exactly what we were doing, and then we waited to see what happened.